Hi, this is Dr. Mahadevan, and now we're going to move into the initial management of trauma patients, part 3. And this lecture is really going to focus on circulation. And when we're talking about circulation and we're doing a focus assessment, we have 3 questions again that we want to ask. The first is there active external bleeding, in which case we want to stop it immediately? Is the patient in shock? And then finally, is there active internal bleeding that we have to diagnose and address? So the focused assessment of circulation: is there active external bleeding? Is the patient in shock? And is there active internal bleeding? And our priorities when we're dealing with a patient who has an issue with circulation is, again, to stop external bleeding, to assess for and recognize shock, and we'll talk about how to do that, and then to identify the cause of shock and to treat it simultaneously. So again, the first priority is going to be to stop external bleeding, and the means that we can do that are as follows. The most common way to stop external bleeding is to provide direct pressure. If that fails and you have a blood pressure apparatus, you can inflate it to above the patient's systolic blood pressure, and that may stop the bleeding. And then in circumstances where that fails, we may need to resort to a tourniquet in order to stop the bleeding and save the patient's life. And as you can see in this particular image, this patient has a very severely injured extremity, and placement of a tourniquet in this case is life-saving. So first priority with circulation: stop external bleeding. When we're assessing circulation, we want to assess the patient's level of consciousness. We want to assess their skin. Is it ashen or gray, suggesting shock? Are their extremities cool or pale, again, suggesting shock? Is their pulse abnormal? Is it rapid? Or are they tachycardic? Is it thready or difficult to palpate? And again, the places that we can palpate a pulse in a trauma victim are in the radial location, femoral, and finally carotid. And generally, if you can palpate a radial pulse, we tend to believe that the patient's blood pressure is at least 80 systolic. And then finally, we want to assess capillary refill. Is it prolonged? And which would be concerning again for shock. So level of consciousness: are they awake and alert, or are they altered? Their skin, their pulse, and their capillary refill. That's the way that we assess circulation. And then when we're talking about shock, shock is not a low blood pressure. Shock represents inadequate organ perfusion and tissue oxygenation. That's very, very important. If you're waiting for a specific low blood pressure to diagnose shock, you're going to miss it. The most common cause of shock in trauma victims is hemorrhage. So always keep that in mind when you're evaluating the patients. And most preventable trauma deaths result from the failure to recognize and treat hemorrhagic shock. So remember, hemorrhage is the most common cause of shock, and if we fail to recognize that this patient has hemorrhage and treat it, these patients can ultimately die. And then finally, it's a clinical diagnosis. We don't wait for a low hematocrit to diagnose hemorrhagic shock. You want to make the diagnosis before you get that blood level back. In terms of classes of shock, there are 4 classic classes of shock. Class 1 is a loss of up to 15% of the patient's blood volume. And the first thing you're going to notice in these patients is a mild increase in their heart rate. Class 2 is when you lose 15 to 30% of your volume. And then what you'll start to notice is not only do they have an increase in their heart rate, but also an increase in their respiratory rate. And then their pulse pressure, or the difference between their systolic and diastolic pressure, begins to decrease as well. When you've lost 30 to 40% of your blood volume, you start to see a drop in their systolic blood pressure. And then finally, when you've lost more than 40% of your blood volume, you start nearing death. So these are the classes of shock, the 4 classic classes of shock. When we are looking for signs of shock, the earliest signs are an increase in the patient's heart rate and then cutaneous vasoconstriction. Those are the earliest signs of shock. So anyone who is cool and tachycardic should be presumed to be in shock. So again, other signs of shock include decreased bentation, as I mentioned, poor capillary refill. Then you start to see weakening or diminished pulses. And the next step is a narrowing of the pulse pressure. So they may start off 140/80, and then their next blood pressure is 120/90. And that might be a subtle clue, this narrowing of the pulse pressure. Initially, the pulse pressure is 60. Here it's 30. As you follow the trend, you might see that the pulse pressure is narrowing. And then you'll start to see decreased urine output, and hypotension or a low systolic blood pressure is going to be a late finding. So really the keys are to look for these early signs of shock and diagnose shock before the patient develops hypotension. Keep in mind that very young patients and healthy adults will maintain their blood pressure until they crash. So even in the face of very severe blood loss, they may have a normal blood pressure. So remember, the absence of hypotension does not exclude shock. Look for the other signs of shock, which are generally present before the patient crashes. In terms of the causes of shock, as I mentioned before, the causes that you want to be worried about is bleeding, either external or internal. It's the number 1, 2, 3 cause of shock in a trauma patient. If you determine that the patient is not bleeding, worry about other causes of shock, including tension pneumothorax that we've already discussed, and something that we're going to discuss in this lecture, cardiac tamponade. And then think about other causes of shock in the trauma patient, things like spinal shock or neurogenic shock, and then other non-traumatic causes of shock, such as dehydration, sepsis, and myocardial infarction. But remember, the most common causes of shock, the one that you always want to keep in your mind, are bleeding. Again, hemorrhage, the most common cause of shock, so look for it. And in a patient with an isolated brain injury, if you find that they only have a head injury and they're in shock, you look for another cause of shock, because an isolated brain injury does not cause shock. So you have someone with a head injury, a subdural hematoma, and they go into shock, keep looking for hemorrhage, because it is very unlikely that the brain injury is the reason for the shock, and they may have another area of shock. So where are the places that you're going to look for occult blood loss in that patient? You're going to look in the chest. We already mentioned massive hemothorax. And this is a checklist, this cramp mnemonic is a checklist that you want to go through in your mind. So you have a patient who is hypotensive or in shock. You're not sure whether they're losing blood. Remember the mnemonic cramp. So again, think about bleeding into the chest, into the retroperitoneum, into the abdomen. Look for a missed long bone fracture, such as a femur fracture, which can cause blood loss, especially in children. And then finally, the pelvis is another area where you can lose a lot of your blood volume. So again, in terms of occult areas for blood loss, chest, retroperitoneum, abdomen, long bones, and pelvis. Remember the mnemonic cramp. In terms of the treatment of someone with a circulation problem, a trauma victim who has a circulation issue, first step again is going to be to control external bleeding, as we mentioned, either through direct pressure or using a pneumatic device to stop the bleeding, or finally a tourniquet. And then you're going to want to establish vascular access. And we always want to put in 2 large bore peripheral IVs, short and fat IVs, to deliver the maximum amount of volume over the shortest period of time. And then other options include central venous access, an IO, or a peripheral cut down if you need access in this trauma victim. And then you're going to want to restore volume. And the first step, or the first item that we use generally, is going to be warmed isotonic electrolyte solutions, such as lactated ringers or normal saline. And the dose in adults is going to be 1 to 2 liters. And in children, 10 to 20 milliliters per kilogram. And then if they still require volume after providing isotonic electrolyte solutions, the next step is going to be to administer blood. And generally, if we're not sure of the patient's blood type, we're going to start with O-negative blood. So step 3 in treating circulation, restore the volume, the blood volume. A common mistake that's made in a patient with hemorrhagic shock is to continue to give IV fluids when in fact the patient is losing blood. And just keep in mind, IV fluids do not replace blood. Do not increase your oxygen carrying capacity. They do not provide red blood cells and hemoglobin. If a patient is in hemorrhagic shock, you want to provide or replace blood, and then you want to stop that bleeding wherever it is, either externally or internally. Don't continue to give them IV electrolyte solutions. Step 4 is to remove an obstruction if the patient has one. We talked about tension pneumothorax already. In a patient with tension pneumothorax, we're going to insert a catheter over needle into that second intercostal space in the midclavicular line over the rib to relieve the tension pneumothorax. But what if the patient has cardiac tamponade? Let's talk about that next. Cardiac tamponade is bleeding into that pericardial space around the heart. What can happen is the fluid accumulates in that pericardial sac, is that it can put pressure on the heart and interfere with cardiac filling. If the heart can't fill with blood, eventually the patient will go into shock. How do you differentiate this from the other causes of shock, such as tension pneumothorax? Unlike tension pneumothorax, these patients generally, unless there's another injury, will have normal breath sounds. However, like tension pneumothorax, they may have distended neck veins, and eventually they will develop shock and potentially die. Their tracheas are usually midline, and they may develop a tachycardia as a result of the accumulation of fluid within their pericardial space. The classic signs and symptoms of pericardial tamponade or cardiac tamponade are something called Beck's triad, which are hypotension, muffled heart sounds when you listen with your stethoscope, and distended neck veins as seen here. Unfortunately, these clinical findings are often late, and so relying on Beck's triad to make the diagnosis of cardiac tamponade is fraught with difficulty and can lead to a late diagnosis. So instead, we want to assess these patients earlier with bedside ultrasound. And what do we see on ultrasound? Generally, what we'll see is the accumulation of blood, again, around the heart. So what we're seeing here is blood accumulating around the heart in the pericardial space. And then what you'll see on this echo is right ventricular collapse during diastole. Remember, during diastole, the right and left sides of the heart, the right ventricle specifically, are going to fill with blood. But in pericardial tamponade, as the pressure increases in the space around the heart during diastole, what can happen is you'll see collapse of the right ventricle, and you're going to see that right here. So let's take a look at pericardial tamponade and what we see. Again, fluid around the heart, and then during diastole, you see collapse of that right ventricle, which is abnormal, and eventually this patient will develop shock and then die. What is the treatment of pericardial or cardiac tamponade? Again, you're going to want to replace volume, so it's fluid resuscitation, and then you're going to want to remove that blood from around the heart. So we do something called pericardial centesis, where we actually insert a needle into the pericardial space and remove that blood. Sometimes the blood is clotted and pericardial centesis doesn't work, in which case the definitive treatment is to go to the operating room and have a pericardial window done to allow evacuation of that blood. And if the patient crashes, they may require an emergent thoracotomy in the emergency department itself. What are the other facets of the treatment of circulation? Step number 5 is, again, to stop internal bleeding. And there are a number of ways we can do that. This is a patient with a pelvic fracture who is having his pelvis bound in order to reduce his pelvic volume and stop bleeding. We can also put patients with femur fractures into traction. You can go to the operating room to stop solid organ bleeding from the spleen or liver. And now we can use angioembolization to go to the interventional radiology suite and embolize bleeding blood vessels there. And then finally, we want to consider other causes of shock, such as neurogenic shock or sepsis in these patients with circulation difficulties. Just to show you what pelvic binding is able to accomplish, here is a patient with a fracture of their pelvis, and as you can see here, significant diastasis of their symphysis pubis, leading to increased volume within their pelvis. And what can happen is because of this increased volume, they can bleed within their pelvis. And so what you want to do is close the pelvis so we can tie this pelvis. And following tying the pelvis, what you can see is there is reduced pelvic width, reduced pelvic volume, and this can tamponade the patient's bleeding. So a life-saving therapeutic option in a patient with an open pelvis fracture or an open book pelvis fracture would be tying their pelvis. When we're talking about circulation, the focused assessment wants to answer 3 questions. Is there active external bleeding, in which case we want to stop it immediately? Is the patient in shock? And keep in mind again, when I say shock, I don't mean hypotension. I mean that they have tachycardia or cool extremities or other signs of shock. And then finally, is there active internal bleeding, in which case we need to identify it, transfuse the patient or give them fluids or volume, and then stop it. Our priorities, again, in dealing with a patient with circulation issues, a trauma victim with abnormalities of circulation, are to stop external bleeding, assess for and recognize shock, and as I mentioned, look for the early signs of shock, cool extremities or cutaneous vasoconstriction, tachycardia. That will progress to altered mental status, narrowing of the blood pressure, or the pulse pressure, I should say, and eventually that will lead to decreased urine output and hypotension. Identify the cause of shock and treat it simultaneously. And that has been the initial management of trauma patients, part 3.